Thank you very much, Dr. Tellem, Dr. Marino, for the opportunity to be here, a part of this session. This is my disclosure slide, which bears no relationship to anything I'm going to speak about today. I think you're going to hear probably some repetition and some things that are emphasized over and over again as a part of this session. And I actually think that's a really good thing, because there are some definite common themes that we'll go through. I have to start every talk about difficult gallbladder, just a reminder about the Safe Coli program, and the mission is to have a universal culture of safety to minimize the risk of bile duct injury. And the 6-step program, which is we put this out probably 8 or 9 years ago now, and I still think this is, if they're just these things that you remember to understand these important principles, that should really enhance safety around this operation. So I thought I would just start, rather than jumping right in about Fenestrate or not, a little bit about, when and why on the subtotal cholecystectomy. Dr. Deal has touched on this. I think there are two main reasons. It's to avoid, biliary or other injury when you've got severe inflammation, and major bleeding and cirrhosis portal hypertension when you've got a lot of collaterals. And then you've heard about the zone of danger. And I think one of the most challenging parts for us as surgeons is to recognize when we get to the point where we're not making progress, this is going to be treacherous, and you're going to be at increased risk for injury, and finish the operation by another method. There are 3 potential scenarios, and Steve Strasberg's talked about this when the CVS can't be obtained. So one is you can't find the gallbladder, and that's rare, and you're probably better off backing out and then sending that patient elsewhere. And I've had a couple of patients referred to me over the last few years that that's exactly what's happened, and I would consider that a sign of very good surgeon judgment. Second scenario is you can only get to the dome, you can't do anything else, and if that happens, just put a tube in, back out, and come back and fight that battle later. The third, which is more common, is that you get to the hepatocystic triangle, you just can't safely dissect it. So one option is convert to open, and the other option is to do a subtotal. And I think we have to remind ourselves always that you never have to do a total cholecystectomy for benign disease when the potential risk exceeds the benefit. Now, what about, and why is that the case? What are the difficult cholecystectomies? So Dr. Nasser in the UK did a very nice study of over 8,800 patients. It's a multi-center study. And they looked at BDI rates under 4 grades of gallbladder pathology. Grade 1 was the easy, straightforward gallbladder, to grade 3, where there's some acute inflammation, a little fibrosis, and then grade 4, empyema, gangrene, dense adhesion, cystic pedicle, impossible to clarify. That's the scenario that's appropriate for subtotal cholecystectomy. And look at the BDI rate in that situation. It was 1.7%. So you've heard some about the risk factors, duration of symptoms. White count greater than 18,000 is a big red flag. If you can palpate the gallbladder, you know that's going to be more difficult. Older age, especially older men, and the other conditions that Dr. Deal mentioned. And so I'll just play a little. How do I get to the, I don't see my mouse on the, how am I able to get, oh, it's off the screen. Yeah, sorry. Let's see. There it is. Good. Yeah. So I think if you look at this gallbladder, this is a scenario where there's a lot of fibrosis, biliary inflammatory fusion that extends down into the porta hepatis. This is a scenario where a total cholecystectomy is not going to be safe. Whether you try to do it with a conventional approach or even top down, you're going to be at risk for injury. Now, as you all are aware, I'm sure we had a multi-society consensus conference on safe cholecystectomy that was published in 2020, and there were 2 questions in that consensus about difficult gallbladder, whether you should do fundus first versus subtotal, or when the CVS couldn't be obtained, or should you do subtotal versus total laparoscopic or open in marked acute inflammation or chronic inflammation. And the recommendations for both of those, and these were expert opinion because of a paucity of evidence, is that surgeons should consider subtotal cholecystectomy, either laparoscopic or open, over total cholecystectomy by the fundus first or top-down approach. And I think we do have to be a little careful that we don't let the pendulum swing too far towards subtotal cholecystectomy anytime it's just a little bit difficult, but under these special circumstances. Now, there was a paper published last year in the Journal of American College by Dr. Jayaraman's group at University of Toronto, thinking your way through a difficult cholecystectomy, technique for high-quality subtotal cholecystectomy. There's a lot of really valuable information in this paper. I would strongly encourage you to take a look at this. And I wrote a commentary for it. I think one of the take-home messages from today is that the devil is in the details of how you do this and how you approach it. So this is from a paper published a few years ago to clarify some of the terminology. We don't call it partial cholecystectomy, it's subtotal. You resect or leave the posterior wall of the gallbladder on the liver. Either way, there's a small gallbladder remnant. It's really important to get all of the stones out, and then you either oversew the neck or close the neck off or leave it open. That's fenestrating versus reconstituting. You should image the biliary tree if it's feasible. That may be an intraoperative cholangiogram, it might be ultrasound, it might be ICG, whatever. And then you should always drain the gallbladder fossa. So first question, what's the best method, lap versus open? Well, let's look a little bit at resident experience with open cholecystectomy. So these are RRC data from 2018-19, and you could probably get the same data if you went back 10 or 15 years further. So residents do a lot of lap choles, which is great, but they don't do very many open cholecystectomies. And the average total was only 8.4, and I suspect some of those were probably done incidentally as a part of a Whipple procedure or something else. So general surgery graduates over the last 10, 15, probably 20 years have very little experience with open cholecystectomy. And so converting laparoscopic to open may not be the default. If you have bleeding you can't control, absolutely. But just for a difficult gallbladder, it may be better just to manage that laparoscopically. I'm going to show a little bit of a video clip. This is from Fernando Santos, and it's a really nice demonstration of subtotal cholecystectomy. You see here things are really sucked in the hepatocystic triangle. You want to open up the gallbladder well above the potential area of danger zone and get all of the stones out from that. And you should have a mechanism for retrieving those stones when you do it. You don't want to have missed or lost gallstones. Here you can see this is a very fibrotic neck of the gallbladder. It can be helpful to use an advanced energy device when you're in one of these difficult gallbladder scenarios. Here he is just really washing this out and flushing this out. You can see the gallbladder itself is rather contracted as well. I'm going to fast forward through this a little bit. This is just taking out off a part of the wall of the gallbladder. And then you get, oops, sorry, apologies. Let me just fast forward on this. So you get that part of the gallbladder off, and now you can see a cystic duct orifice. That's not always possible to visualize that, and even if you do, you may not be able to get a catheter in it. But if you can see it, I would at least try to do that for a couple of reasons. One, to verify your anatomy, and two, to make sure you're not missing any stones. If you can see that clearly, you can carefully place a stitch across the cystic duct orifice. You don't want to get this too deep because you don't know exactly where the bile duct injury is for sure. And then you should always leave a drain at the end. So let's look at a couple of studies. This is an interesting study that was recently published from Dr. Mercado's group at Mexico City. And they looked at 115 patients who underwent subtotal cholecystectomy and compared it to patients that were referred to their center who had bile duct injuries. They did have 21% of the subtotal group had bile leaks. There was only one BDI. Reoperations were a bit more frequent in the BDI group, but none of them required subsequent reintervention or completion cholecystectomy. At 8 years of follow-up, there were 2.4% of patients in the BDI group who had biliary stenosis. So this is the scenario of relative balancing the risks of a bile leak and other things with subtotal versus a total cholecystectomy in that group, and the bile duct injury patients obviously had more severe ultimate consequences, and that's what we're trying to avoid. This is a recent literature review of publications of subtotal cholecystectomy that compared reconstituting versus fenestrating, and that speaks to the issue of this particular debate. So there were 570 published fenestrated, 935 reconstituting. The conversion rate was higher in the fenestrating group. It's a little unclear. Why would that be the case? It doesn't really clearly make sense, and these studies were over an extended period of time. There were 4 bile duct injuries in the reconstituting group, 1 in the fenestrating, not significant, but still a bit concerning. Bile leak rate was actually 16% in the reconstituting group. It was a bit higher in the fenestrating, and that's one of the downsides of the fenestrating. Retained stones, 4 to 7%, and there was a higher rate of post-op ERCP in the fenestrating group. There's a little bit of problem with this literature, though. There were, sorry about that. The follow-up was less than 12 months in most of the studies. 1/2 of the studies that were analyzed were prior to 2014, 2 of which had a large number of cases. So I think there's a lot of older data in this systematic review. And there were only 8 of the 39 studies that had both fenestrating and reconstituting cases. So this is a little bit comparing apples to oranges. One of the best studies comes from the Netherlands. And this is a retrospective study of 191 patients from 4 teaching hospitals. They had pretty good follow-up of 6 years. There were a few more fenestrating than reconstituting that were in the analysis. And as you might predict, the rate of bile leak was higher in the fenestrating group than it was reconstituting. But the risk of recurrent biliary symptoms was higher in the reconstituting group. And there was 1 BDI in the reconstituting group. I have personally taken care of 5 or 6 patients now over the last 5, 6 years who've had remnant gallbladder disease that had to go back and take that out. That's a difficult operation. And so I think when you're doing this operation, you want to make sure you've gotten all of the stones out and leave a very small cuff so you don't reconstitute that gallbladder and run the risk of developing recurrent gallstone disease. So I would just kind of summarize the pros and cons of this debate like this. The technical ease, in my view, that should be pretty neutral. I think you can do either. I think sometimes the risk perhaps of reconstituting, if you haven't really opened it and you just get down to a little bit of a neck and you put a stapler across it, you don't know what's left in that gallbladder. So I would not encourage that. Ability to perform IOC, that favors the fenestrating. Risk of retained gallstones, that favors fenestrating. Bile leak need for ERCP, that probably favors reconstituting. I will admit that. Risk of BDI, I think that probably favors fenestrating, but the data are really limited on that. And risk of future remnant recurrent gallstone symptoms or disease, that should favor fenestrating. We don't have good data on that, but that's a concern the long term for using a reconstituting approach. So if I can summarize, subtotal cholecystectomy should be the safest option to eliminate gallstone disease and mitigate against the risk of BDI in the most challenging gallbladder scenarios when you can't safely dissect the hepatocystic triangle. Either lap or open is acceptable, but that really depends on your skill set and experience, and I think the balance is probably, the scales are probably tipped towards doing these laparoscopically today. Fenestrating subtotal cholecystectomy is probably the better option rather than reconstituting to minimize the risk of recurrent gallbladder disease. And I think, as is often the case, the devil's in the details of how this is done in order to get the best possible outcome to minimize the risk of bile leak and future disease. And just like Dr. Deal, I'll just remind you about the Safe Chole modules, and these are now on the SAGE's online web learning system. So I would encourage you and your trainees to take a look at that. Thank you very much.